So, stem cells, stem cells are and their clinical uses and potential. Stem cell transplantation holds great promise for the regeneration of diseased, damaged, or defective tissue. Hematopoietic stem cells are already used to restore hematopoietic function, and their use in the clinic is described below. However, rapid advances in stem cell research have raised the possibility that other stem cell types may soon be routinely employed for replacement of a variety of cells and tissues. Two properties of stem cells underlie their utility and promise. They have the capability to give rise to lineages of differentiated cells, and they are self-renewing. Each division of a stem cell creates at least one stem cell. If stem cells are classified according to their descent and developmental potential, four levels of stem cells can be recognized: totipotent, pluripotent, multipotent, and unipotent. Totipotent cells can give rise to an entire organism. A fertilized egg, the zygote, is a totipotent cell. In humans, the initial developed divisions of the zygote and its descendants produce cells that are also totipotent. In fact, identical twins develop when totipotent cells separate and develop into genetically identical fetuses. So, pluripotent cells arise from totipotent cells can give rise to most but not all of the cell types necessary for fetal development. For example, human pluripotent stem cells can give rise to all of the cells of the body but cannot generate a placenta. Further, differentiation of pluripotent stem cells leads to the formation of multipotent and unipotent stem cells. So, multipotent cells can give rise to only a limited number of cell types, and unipotent cells can generate only the same cell type as themselves. So, pluripotent cells called embryonic stem cells or simply ES cells can be isolated from early embryos, and for many years it has been possible to grow mouse ES cells as cell lines in the laboratory. So, strikingly, these cells can be induced to generate many different types of cells. Mouse ES cells have been shown to give rise to muscle cells, nerve cells, liver cells, pancreatic cells, and hematopoietic cells. Recent advances have made it possible to grow lines of human pluripotent cells. This is a development of considerable importance to the understanding of human development, and it also has great therapeutic potential. So, in vitro studies of the factors that determine or influence the development of human pluripotent stem cells along specific developmental paths are providing considerable insights into how cells differentiate into specialized cell types. This research is driven in part of the greater potential for using pluripotent stem cells to generate cells and tissues that could replace diseased or damaged tissue. Success in this endeavor would be a major advance because transplantation medicine now depends entirely on donated organs and tissues, yet the need for exceeds the number of donations and the need is increasing. Success in deriving cells, tissues, and organs from pluripotent stem cells could provide skin replacement for burn patients, heart muscle cells for those with chronic heart disease, pancreatic island cells for patients with diabetes, and neurons for the treatment of Parkinson's disease or Alzheimer's disease. The transplantation of hematopoietic stem cells is an important therapy for patients whose hematopoietic systems must be replaced. It has three major applications: providing a functional immune system to individuals with a genetically determined immunodeficiency, such as severe combined immunodeficiency, replacing a defective hematopoietic system with a functional one to cure patients with life-threatening non-malignant genetic disorders in hematopoiesis such as sickle cell anemia or thalassemia, and restoring the hematopoietic system of cancer patients after treatment with doses of chemotherapeutic agents and radiation so high that they destroy the system. These high dose regimes can be much more effective at killing tumor cells than therapies using more conventional doses of cytotoxic agents. So, stem cell transplantation makes it possible to recover from such drastic treatment. Also, certain cancers, such as some cases of acute myeloid leukemia, can be cured only by destroying the source of the leukemia cell, the patient's own hematopoietic system. Hematopoietic stem cells have extraordinary powers of regeneration. Experiments in mice indicate that a few as one HSC can completely restore the erythroid population and the immune system. In humans, as little as 10% of donors' total volume of bone marrow can provide enough HSCs to completely restore the recipient's hematopoietic system. Once injected into a vein, HSCs enter the circulation and find their own way to the bone marrow, where they begin the process of engraftment. There is no need for a surgeon to directly inject the cells into bones. In addition, HSCs can be preserved by freezing. This means that hematopoietic cells can be banked. After collection, the cells are treated with the cryopreservative frozen and then stored for later use. When needed, the frozen preparation is thawed and infused into the patient where it reconstitutes the hematopoietic system. This self-freezing technology makes it possible for individuals to store their own hematopoietic cells for transplantation to themselves at a later time. Currently, this procedure is used to allow cancer patients to donate cells before undergoing chemotherapy and radiation treatments, then using their own cells later to reconstitute their hematopoietic system. Hematopoietic stem cells are found in cell populations that display distinctive surface antigens. As discussed in the text, one of these antigens is CD34, which is present in only a small percentage, 1% of cells in adult bone marrow. An antibody specific for CD34 is used to select cells displaying this antigen, producing a population enriched in CD34 plus stem cells. Versions of this selection procedure have been used to enrich populations of stem cells from a variety of sources. So, transplantation of stem cell populations may be autologous. The recipient is also the donor, or synergistic. The donor is genetically identical, the identical twin of the recipient, or allogenic. The donor and recipient are not genetically identical. In any transplantation procedure, genetic differences between donor and recipient can lead to immune-based rejection reactions. Aside from host rejection of transplanted tissue, host versus graft, lymphocytes conveyed to the recipient via the graft can attack the recipient's tissue, thereby causing graft versus host disease, or GVHD, a life-threatening affliction. In order to suppress rejection reactions, powerful immunosuppressive drugs must be used. Unfortunately, these drugs have serious side effects, and immunosuppression increases the patient's risk of infection and susceptibility to tumors. Consequently, HSC transplantation has fewest complications when there is genetic identity between donor and recipient. At one time, bone marrow transplantation was the only way to restore the hematopoietic system. However, the essential element of bone marrow transplantation is really stem cell transplantation. Fortunately, significant number of stem cells can be obtained from other tissues, such as peripheral blood and umbilical cord blood. These alternative sources of HSCs are attractive because the donor does not have to undergo anesthesia or the high invasive procedures by which bone marrow is extracted. Many of the transplantation community believe that peripheral blood will replace marrow as a major source of hematopoietic stem cells for many applications. To obtain HSC enriched preparations of peripheral blood, agents are used to induce increased number of circulating HSCs, and then the HSCs containing fraction is separated from the plasma and red blood cells in a process called leukapheresis. If necessary, further purification can be done to remove T cells and to enrich CD34 plus population. Leukapheresis. Umbilical cord blood already contains a significant number of hematopoietic stem cells. Furthermore, it is obtained from placental tissue, the afterbirth, which is normally discarded. So, consequently, umbilical cord blood has become an attractive source of cells for HSC transplantation. Although HSCs from cord blood fail to engraft somewhat more often than do cells from peripheral blood, grafts of cord blood levels produce GVHD less frequently than marrow grafts, probably because cord blood has fewer mature T cells. Beyond its current applications in cancer treatment, many researchers feel that autologous stem cell transplantation will be useful for gene therapy. The introduction of a normal gene to correct a disorder caused by a defective gene. Rapid advances in genetic engineering may soon make gene therapy a realistic treatment for genetic disorders of blood cells, and hematopoietic stem cells are attractive vehicles for such an approach. The therapy would entail removing a sample of hematopoietic stem cells from a patient, inserting a functional gene to compensate for the defective one, and then re-injecting the engineered stem cell into the donor. The advantage of using stem cells in gene therapy is that they are self-renewing. Consequently, at least in theory, patients would give to receive only a single injection of engineered stem cells. In contrast, gene therapy with engineered mature lymphocytes or other blood cells would require periodic injections because these cells are not capable of self-renewal. Then different lineages of maturational stages of lymphocytes can be distinguished by their expression of membrane molecules recognized by particular monoclonal antibodies that are specific for a single epitope of an antigen. All of the monoclonal antibodies that react with a particular membrane molecule are grouped together as a cluster of differentiation CD. Each new monoclonal antibody that recognizes a leukocyte membrane molecule is analyzed to determine if it fails within a recognized CD designation. If it does not, it is given a new CD designation reflecting a new membrane potential. Although the CD nomenclature was originally developed for the membrane molecule of human leukocyte, the homologous membrane molecules of other species, such as mice, are commonly referred to by the same CD designations, CD markers found in human lymphocytes.